Okay, I think what we'll do is we'll start and we'll see others join in. So good evening, everyone from India. Thank you so much for coming to this 90-minute session, which is part of the London Global Cancer Week. There are several exciting sessions in oncology, but also in pediatric oncology during the whole week. And the Indian Pediatric Hematology Oncology Group got an opportunity to host one such session. I'm Ramandeep Arora. I'm a pediatric oncologist, and today we are talking about improving childhood cancer outcomes in low and middle income countries through multi-center collaborative research. And we have a great panel of speakers as well as panelists who are going to share their wisdom and experience with you. Let me go to the next slide. Okay, so I want to focus very briefly on three words: outcomes, countries, and collaborative research. And all of us in childhood cancer love to see this slide, and you will see this again and again. And essentially, it shows how outcomes have improved in childhood ALL, and this is from the COG group. Now, a big part of this has been collaborative research. And the reason why we do collaborative research is because the number of children with cancer is limited. And so if we want to answer questions, we need to come together. It's a very specialized field. And if you just do the maths and you say, okay, there are 250,000 children annually with cancer, and historically, all these studies have been done in high-income countries where 20% of the kids reside. That's 50,000 children in the entire world put together per year. A quarter of these have ALL, only 1% have hepatoblastoma. So if you want to answer a question, it is very difficult for one center or even one country to try and answer all the questions. And that is why collaborative research has been so essential and critical to the global context. Now, within this, I've just picked up one study. You all know this very well, the Inter-Retux NHL 2002, which picks up a WHO index cancer of BNHL. What is remarkable is the red and the gray. So the red is high-income countries of Europe and North America and Australia and Japan and so on. And the gray is the rest of the world. And so this country and patients with this disease can enroll into this trial, but the rest of the world can't. Now, if you contrast this map with this paper which came out, or this map which came out a few years earlier, which shows the regional collaborative efforts in low-middle-income country in childhood cancer. And it complements the grays which is seen in the left-hand map with the color which is seen in the right-hand map, and shows the efforts that are being made to begin with South America, but then later other parts of the world, North Africa, Asia, etc., who are catching up. And this is what this particular session is trying to showcase and highlight as to how collaborative efforts in low-middle-income countries are happening and changing what we do. So with this, I introduce the speakers, and we would first talk about speakers from India who showcase the work which has been done by the Indian Pediatric Hematology Oncology Group, followed by a panel discussion by three expert panelists who have been involved in the creation of the building blocks which make such collaborative research happen. So I would like to invite Dr. Gauri, who is a director of the Pediatric Hematology Oncology Group at Rajiv Gandhi Cancer Institute in New Delhi, India, and is also one of the directors of the Indian Pediatric Hemong Group. Just before she starts, can I also again welcome all of you and request that if you have not put your name on your, next to your icon, please do that and identify yourself if possible with the country. And then at the end of the three talks, we will have chances for Q&A. So please put your questions in the chat box. Thank you so much.
Thank you, Ramandeep, and good evening, everyone. So it's my pleasant duty this evening to walk you through the journey, the progress, and the future plans of the Indian Pediatric Hematology Oncology Group. So how did we start? Briefly, the whole thing started in 2007, which was a landmark year for us. The PSYOP Annual Congress was held in Mumbai for the first time in that year. And the vision and plan was set in motion for a collaborative group. Probably we got the impetus through the interaction with many of the PSYOP delegates and seniors. So the next year, in September 2008, we held the first meeting of the Indian National Pediatric Oncology Group under the aegis of the Indian Council of Medical Research, our medical research body, national body, and it was held under the umbrella of the Pediatric Hem-Onc chapter's annual conference. So it was held at that time in New Delhi. And you can see the 30-odd pediatric oncologists. We just had about 45 people working in pediatric oncology at the time, nationwide. Isn't that surprising? So I'll take you through our journey in 3 phases. The first phase, as you can see here, was basically started in 2008. And in that, we had multiple meetings. We discussed how to take this movement forward because India was a large country. Certain SOPs were discussed. However, it was kind of slow at that time, trying to get the critical mass in, trying to get everybody's interest at par, and many other competing priorities. And I'm showing you here the first office bearers with senior advisors discussing how to take the Indian Pediatric Oncology Group forward. So phase 2, 2015, we gained momentum with the formation of the first executive of the INPHOG, which had 5 dynamic leaders. What did they do? So it was very important to carry the pediatric hem-onc community together with us in this initiative. We used the platform of the Pediatric Hem-Onc IAP chapter, and we got more members in, we got interested individuals. We used the PODC, PSYOP PODC model, and we decided that we really needed to quickly provide the framework on how to take these studies forward. So we formed disease subcommittees, and chairs were nominated, members were nominated, roles and responsibilities were handed out. A study roadmap was created along with authorship guidelines. A basic reporting infrastructure was also created, and we maintained regular communication, which was really, really important because India is a very large country, and we had more than 400, 500 members of the pediatric hemo community whom we needed to keep informed and keep abreast of what was happening. And these quarterly newsletters did that for us. And with that came the initiation of the multicentric studies, which initially were retrospective due to the paucity of funds. The third phase, starting in 2018-19, was very, very significant in that, firstly, INPHOG changed to INPHOG, Indian Pediatric Hematology Oncology Group, because our Pediatric Hem-Onc chapter gave us the mandate that benign hematology must be included because we had lots of children with benign hematological disorders, and they were taken care of by the same clinicians who did pediatric oncology. The second very significant development was registration of INPHOG as a Section 8 company in December 2021. What is a Section 8 company? It is basically a not-for-profit company which allows us certain tax exemptions under the government's tax structure, and it helps us in taking and disbursing funds for clinical trials and for clinical research. And so came into being the INPHOG Research Foundation. So we had a mission to improve outcomes of children with cancer and benign hematological disorders in India by collaborative research, and an objective to promote regionally relevant pediatric cancer and hematological research, including multi-center clinical trials in India, so as to generate evidence in the local population and improve outcomes. The activities were predominantly oncology. We had a brand new logo. You can see that on the right-hand upper corner, and on the lower corner, you can see we created our website, the www.inphog.org. We also have the executive board in this research foundation, INPHOG Research Foundation, which has Amita, Revathi, Girish, Ramandeep, and myself. This is the first executive. And we are very fortunate to have an advisory board, which has all these eminent luminaries, Professor Kathy Pritchard-Jones, Professor Carlos Rodriguez Galindo, C.S. Pramesh, Nihal Kaviratne, and Nachiket Moore, who have given us their thoughts, ideas, visions, and guidance to help us take this to the next level. As you can see, we have also been quite active in recruiting members, the INPHOG delegates, the INPHOG member delegates, and the INPHOG member institutions. We have a total of 235 delegates so far, 159 from 43 INPHOG member institutions, and 76 from 61 non-member institutions. So you can see here that 60% of these primary delegates are actually clinicians, pediatric hematologists, oncologists, and the rest are pediatric surgeons, radiation oncologists, pathologists, radiologists, orthopedic surgeons, etc. So we have 27 disease-specific and transdisciplinary subcommittees from across the country. You can see the dots on the map. All over, all zones of the country are involved in these studies. 32 studies, of which 16 are completed and 12 are currently recruiting. And we have almost 13,000, a little over 13,000 patients enrolled in the 24 clinical trials. This is showing us the time trend of the studies. The red line are the 122 centers which have been recruited from 2014 till now. The gray line shows the number of patients recruited, and the blue line is the number of studies. And you can see that in recent times, there has been a sharp increment in all the three. So the study portfolio shows that we have diseases, the various disease groups which are involved in the studies are the leukemia, lymphomas, followed by solid tumors, the transdisciplinary, which are the supportive care and survivorship studies, and the benign hematology studies as well. So we have 15 peer-reviewed journals, 15 publications in peer-reviewed journals so far, and 26 presentations in various forums in national and international. The funds that we have received so far are about $820 US. However, we still have just 2% of children of our country enrolled in these studies, and we therefore have a long way to go, definitely. So these are some of the publications, and these are the milestones I will show you. So the first multicentric study actually started before INPHOG, which was created in 2008. First trials were done in 2015. 10,000 patients were enrolled by 2020, and we got registered as a Section 8 company in 2021. So where do we want to go? As you can see here, we want to really have clinical frontline prospective trials in all of the 6 WHO Global Initiative identified diseases. And if you see here, we have almost 2 in all of them. And if you look at this, we can see that the main 6 studies for the next 12 months are listed here. And in the following year, we have these low-grade glioma and the BNHL study planned. A very ambitious plan is also to have a hospital-based cancer registry for each and every INPHOG institution, and I'm sure we'll get there soon. And finally, I would like to thank our partners, the Pediatric Hem-Onc chapter of IAP, Resonance, CanKids, SciOp Park, and Mission Samriddhi, without whose help we would not have been able to reach here. And I hope, and I'm sure that we will have their continued support in the times to come. Thank you very much.
Thank you, Dr. Gauri. I would request, I will move on to the next presentation. And at the end of all the 3 presentations, we will have some time for questions. Once again, I can remind all those who are attending, welcome to this event. And if you have any questions, please feel free to put them in the chat. So our next speaker, next two speakers actually focus on leukemia and Hodgkin's lymphoma and the work done in INPHOG in this regard. So Dr. Venkatraman Radhakrishnan is a professor of medical and pediatric oncology at Chennai, and you will all remember he won the Hans-Peter Wagner Award in PSYOP a few weeks ago. So Venkat, please go ahead. Thank you.
Thanks, Raman. I just need to share my slides.
Yeah.
Are the slides visible?
Yes, please. Go ahead.
Yeah, thank you. Thank you for the opportunity. So Raman has shown these slides, and we have seen the remarkable achievement in terms of survival going almost up to 90% in pediatric ALL in the Western world. And this was achieved just conventional chemotherapy and BMT. And this is our dream. And this was achieved through clinical trials, protocol-based treatment, collaborative networks, research, and funding. All those things are very difficult to get in an LMIC setting. And this gap, we call this a survival gap between low-income countries and high-income countries, needs to come down if we want to improve the overall survival of children with ALL across the world. And just like we had this endured survival, and this is the survival from our institute over the last 4 decades, basically 3 decades. So we had this 10% improvement from 20% to 30% to 40%. And in the early 2000s, it had gone up to 60%. Yes, the increments are happening. They're happening at a 10% per decade, but we have another 30-40% of the gap which needs to be filled. So why does this gap come? And one of the important reasons why we get this gap is very high treatment-related mortality. Almost 40 to 50% of deaths in LMICs occur in the first 8 weeks during the induction and early phase of consolidation. There's also a high rate of relapses which is seen in India and other LMICs. And there's actually not much data. Most of the data is from single-center retrospective studies, and all these patients have received standard chemotherapy without any risk stratification. And this is why the outcomes have lagged behind. And therefore, there's an urgent need to have cooperative multicentric approach for treating pediatric ALLs in India and other LMICs. And there are various barriers. You can't find solution to improving pediatric ALL outcomes overnight. There is problems with infrastructure, manpower, lack of trained hospitals, doctors, drug quality, availability, access to transplants, immunotherapy, funding for research, need for multi-center collaborative trials. There are patient factors including infections, malnutrition, financial toxicity, abandonments, and even a country as big as India, which has a robust cancer policy, doesn't have pediatric cancer in its national cancer policy. So there are policy level issues as well, and diagnostic is not standardized. So you have difficulty in accessing MRD, FISH. So we need to look at all these factors if you want to improve outcomes in ALL, and this can only be done through a collaborative approach. For example, this is our survival in terms of patients who are malnourished versus not malnourished. This, you won't see this much in a developed country, but a 12% gap which can be easily be brought down by just improving nutrition of children whom you treat. Collaborative work in India started almost 3 decades back thanks to the effort of these two individuals, Dr. Shanta, who was the late chairperson, and Dr. Ian McGrath from the National Cancer Institute. Dr. Shanta visited NCI and said, told McGrath that the outcomes with ALL is very dismal in our country, and that was the genesis for the MCP 841 protocol. MCP is the multicentric protocol, 1984, the first version. So this protocol included Cancer Institute, or AIIMS New Delhi, and Tata Memorial Hospital, and managed to recruit almost 1,000 patients. And this was a great success in the late 1980s when there was no internet, there was no trial management systems, and people got together, wrote down handwritten notes, no Excel sheets, no databases, no availability of major drugs. Even vincristine had to be imported. And they did see success. In the late 80s, you had survival as high as 60% reported in TMH and in AIIMS. But after that, for next 2 decades, things quietened up a bit. People again started working in silos. And then thanks to this person, Professor Bhaskar Saha, who rejuvenated patient ALL care in this country and who brought all these centers together. I remember Professor Saha visiting each and every center in India, asking them to collaborate, work together to improve outcomes. And it took him almost 2 years to convince all of us. He would go talk, convince, and won't allow people unless they agree to join his effort. And this was the birth of the ICICL, which is the Indian Childhood Collaborative Leukemia Network. And as I said, this occurred because there were no standard protocols, there were retrospective data, outcomes were poor, patients are dying, treatment costs were high, abandonments are very high. And the idea was to have a risk-based treatment, focusing on diagnostics, treatment, database, reducing relapses, reducing the cost, and decreasing toxic deaths. So ICICL was one man's vision, but it involved a village. So you had investigators from various institutions with a lot of experience. They all got together and agreed to have a consensus treatment. And their stakeholders included the National Cancer Grid, the Indian Council of Medical Research. ICICL was an INPHOG trial. And we had support from NGOs, CanKids, and other trusts. The first is, before we even started ICICL, it was important for us to ensure that we had regular standardization of genetics and treatment and MRD. So there are a series of workshops conducted for both MRD and cytogenetics over the next 4 years. And this ensured that our major ICICL centers spoke to each other in the same language. And once the MRD and cytogenetics were standardized, we moved on to having a pre-trial phase where we tried the ICICL protocol in the centers. And when we are confident, the actual trial started around 2017. And now we have completed recruitment and we're moving towards ICICL 2. So these are the 6 centers in ICICL spread across the country: Chennai, Mumbai, 2 centers in Delhi, Chandigarh, and Kolkata. And we also ensure that each center plays an important role. For example, Tata Mumbai took a lead role in the flow and MRD, whereas TMC Calcutta played an important role in FISH and cytogenetics. They helped in standardization training. We also helped in training these outsourced labs and lab partners, because not all institutions had the facilities, and many of the centers were outsourcing their tests. We realized that over the years, ICICL, although it's still in a trial, was fast adopted by many centers in the country, though they were not part of the trial, but it kind of became a standard of care across the country. This was the disease management system, an industry academia partnership between Tata Consultancy Service and the INPHOG ICICL group. Tata Consultancy Services provided it free of cost to us. This is ICICL protocol as such. Asked 2 randomization questions, one in induction between short course and long course steroids, and the second randomization question, the delayed intensification between doxorubicin and nitazoxanide. A lot of publications and changes have occurred in the landscape of pediatric and AL in India because of ICICL. These are the publications on flow cytometry and FISH. More than about 15 or 20 publications on flow and FISH from the ICICL group. An important part of ICICL was to look at drug quality. There were 2 major publications on the quality of L-asparginase and therapeutic drug monitoring. These were quite revealing, as we found out that most of the L-asparginase available in the country were not of the optimum quality. Methotrexate monitoring is not regularly available in all centers. It's expensive. So there were what we call jugaad in India. That is, we found out ways to have a single value or the max 2 values of methotrexate measurement, and then titrate our treatment. So there were a lot of multiple publications on this as well. The TMC Calcutta did a lot of studies on the target ANC, the 6MP levels, and NUDT. And my paper from Calcutta also showed that the cost effectiveness of ICICL treatment, Nickhill was involved in this. And we also did a study on ICICL patients to show that there's no role of neutropenic diet in patients with ALL. Going on, ICICL became a backbone for testing the generic PEG-L-asparginase, and it was shown that with this PEG-L-asparginase works very well. Dr. Gauri's team did publish a big study on the use of PEG-L-asparginase, the generic PEG-L-asparginase. Chandigarh and Delhi got together and published an important paper on copy number alterations in Indian patients, which has never been done in the past before. We also got a grant from the Indian Council of Medical Research to look at the use of artificial intelligence to predict prognostic and predictive factors in ICICL pre-trial. So you can see that a single trial had managed to change the landscape of diagnostic, treatment, drug monitoring, and evaluation. And this is unpublished data yet. ICICL was a success. we reduced the treatment-related mortality to 8%. It was 11% in the pre-trial. And the overall outcome looks good. Survival rates of almost 86% for the trial cohort. This is still to be published. But yes, we are closing the gap. The gap, which was around 30%, has probably come down to 15, or at the maximum 10% with the ICL protocol. As I said, it was all possible due to the graph I showed before: funders, investigators, charities, database, all coming together in a harmony to make it success. But what after ICL? ICL was in 6 centers, but we want to replicate it all across India. And that was the genesis of the ISCAL study, which is Improving Survival Childhood ALL in India, which is an ICL implementation study sponsored by the Indian Council of Medical Research. And it involves almost every stakeholder in pediatric ALL in this country. The study is a prospective study. We are implementing the ICL protocol standard arm in major public hospitals in India through an hub and spoke model. The idea is to build regional capacity and expertise for both diagnostics and treatment. Also looking at a qualitative study to look at the barriers and enablers of implementing the ICL protocol. There are multiple questions to be answered, including reducing morbidity, improving patient symptoms, improving quality of life, better reach, reducing abandonment, and increasing acceptability by patients and caregivers. These are the ISCAL centers. So the original ICL centers are the hubs, and the spokes are scattered all across the country. So we've ensured that almost the whole country is covered. So the hubs and spokes are divided. So each hub has about 3 to 4 major public hospitals as spokes for them. The deliverables are to ensure that we recruit human resources, develop a data management system. The hub professionals will visit the spokes, train them. We will develop standardizing for reporting the marrows, have quality control for MRD, flow, and fish, ensure appropriate implementation, stratification, and capturing of the data in the data management system. Our goals in ISCAL is to reduce TRMs to less than 5% during induction and 10% across the treatment in all centers, at least have an MRD of 25% by flow in these centers, reduce relapses by less than 15%, and reduce less than abandoned by 2%. Yes, these goals are pretty ambitious, but we would try to achieve them. So what is the future? So ISCAL has almost 28 centers. The idea is that the spokes in future will become mini hubs and will recruit more spokes. Spokes will be future shared care center. ICL is part of INPHOG, and the ISCAL experience can be or should be incorporated for improving outcomes in other pediatric cancers. And we have applied for funding for ICL 2, which is looking at better stratification, genomics, biobanking, personalized medicine. So as I said, our plan is to have a 3-tier system. We don't expect every center to be high-tech, but at least the Tier 1 center should have basic capacity to implement ALL protocols, whereas the Tier 3 is looking at phase 1 and phase 2 trials, advanced diagnostics, RCTs, and biobanking. So thank you for your time. I think I have completed my allotted time. Thank you very much.
Thank you, Venkat. Thank you for finishing very much in time for a great presentation. Rishika, can you put back this? Thank you so much. So next speaker for the first session, and we will take questions after this. And once again, if I can request you to put your questions in the chat as well as add your country next to your name so that people know where you're from. Next speaker is Dr. Amita Mahajan, who is a senior consultant at Apollo Hospital in New Delhi, as well as one of the directors of the Indian Pediatric Hematology Oncology Group, and has spearheaded the collaborative Hodgkin's protocol and trials within the country over the last 5 to 10 years. Welcome, Amita.
Thank you, Raman. Can I share my screen now, Rishika? Yeah, thank you. Raman, are my slides visible?
Yeah, we can see them. Thank you.
So thank you, Raman, and good evening and greetings from India to all of you. As of this year, India is officially the most populous nation in the world. It follows, therefore, that we are expected to have the largest number of newly diagnosed children with Hodgkin lymphoma each year. Hodgkin lymphoma has been eminently curable even in low-middle-income countries for a significant length of time. However, balancing efficacy with long-term toxicity has proven to be an extraordinary challenge, meaning thereby that for our setting, the standard of care continues to remain elusive. This is largely attributable to the wide disparity in access to healthcare that we see in India. Earlier this year, we put a man on the moon, but bullock carts continue to remain a reality for much of rural India on a daily basis. With WHO Cure for All identifying Hodgkin lymphoma as an index childhood cancer, we are committed to universal access to treatment and optimizing outcomes for each individual child with Hodgkin lymphoma. We acknowledge, therefore, and there is a consensus nationwide that collaborative clinical research is no longer a luxury for us, but is mandatory to achieve these outcomes. So over the next few minutes, I'd like to share with you what we have known for some time based on research in India, the more recent INPHOG experience, and what the future holds in this arena for us. Prior to initiating multicentric prospective collaborative work in India, a systematic survey including 13 studies and nearly 1,800 patients reaffirmed that by far ABVD was the commonest regimen used across the country with reasonable outcomes. Where it was tested, the vast majority of patients had EBV-driven disease with its predilection for younger male child and mixed cellularity histology. Despite relatively simple treatment and fairly good outcomes, abandonment was still a major issue. Risk stratification and response adaptation were not being practiced widely, with almost every child getting 6 or sometimes even 8 cycles of ABVD. The practice varied widely across the country with regards to radiation based on the philosophy of the treating teams and access to radiation for children at those centers. Data on late effects was limited, as was the experience with alternative strategies such as the Uronet OEPA-based chemotherapy. What data we had, and though this was a significant volume, it was largely single-center retrospective data from academic institutions. I'd like to specifically share 2 relatively recently published studies. This first study from a very busy center in North India looked retrospectively at its experiencing using OEPA-based, the Uronet-based strategy. 34% of patients warranted radiation based on inadequate PET response at early response assessment, but only about half could actually receive this. Outcomes were reasonable, but a treatment-related mortality in excess of 5% was a cause for concern. Another study based on the OEPA-based chemotherapy from the Tata Memorial Hospital in Mumbai showed excellent outcomes, but this came at a price of nearly 80% of the cohort receiving radiation, and once again, the non-relapse mortality in excess of 4% was disconcerting. The first multicentric prospective collaborative work began in 2015 under the auspices of the Indian Pediatric Hematology Oncology Group, and really in its new avatar, the first effort from this group was a prospective study on newly diagnosed Hodgkin lymphoma, the INPHOG HL 1501. This study employed a very simple risk-stratified response-adapted treatment algorithm using a ABVD chemotherapy backbone. Radiation was limited to sites of bulky disease at diagnosis and sites with inadequate response at early response assessment. The primary purpose was to limit the treatment burden for patients with early stage disease and also at the same time help build a collaborative platform which would then function as a springboard for hopefully many future studies to come. The study hypothesized that for patients with early stage disease, with this simple treatment schema, we would be able to achieve an event-free survival of more than 80% for patients with early stage and more than 70% for patients with advanced stage disease. This slide just shows the treatment schema, the response assessment, and the overall protocol for this study. We did face certain challenges, being the first study that aimed at, having many centers participate without any formal funding or any support given to any of these centers. But once we got the study off the ground, the response was really overwhelming, with 27 centers joining the study across the country, as we can see in this map. We enrolled over 400 patients over 32 months, in fact, ahead of our planned schedule. Of these, 396 had complete data available for analysis. The data had been collected on very simple Google Doc platform. Once again, it reiterated that the median age in children in low middle income countries at diagnosis is much lower than that reported from the Western world, with a very high male preponderance. 2/3 of patients had advanced disease at diagnosis, and nearly half of the patients had B symptoms and bulky disease. Not surprisingly, for low middle income countries, about 1/3 had received empirical anti-tubercular treatment prior to establishing a definitive diagnosis of Hodgkin lymphoma. Perhaps owing to the simple treatment schema, protocol violations and treatment delays were minimal, which was very reassuring. 40% of patients with early disease and 45% of patients with advanced disease received radiation. We could restrict abandonment to under 5%, and only 2 deaths could be attributed as treatment-related mortality, but both of them were non-neutropenic at the time of these infective events. At a median of 52 months from diagnosis, the estimated 5-year event-free and overall survival for patients with early-stage disease was in excess of 95 and 97%. And it was 80 and 90% respectively for patients with advanced stage disease. On multivariate analysis, the only statistically significant predictor of event-free survival for patients with advanced disease was use of radiation. Once again, highlighting that perhaps for advanced stage disease, this chemotherapy is maybe suboptimal. Patients with B symptoms, as expected, had inferior outcomes, but bulk did not impact on prognosis because treatment was actually stratified for bulky disease. As expected, patients with lower hemoglobin and albumin had inferior outcomes. We attempted to identify that if we could really isolate a cohort with extremely poor outcome who could be recognized at the outset and offered referral to a higher center or more intensive treatment wherever feasible, and did need patients with a CHIP score of 4 had really significantly inferior outcomes. A proportion of our patients, close to 10%, were under 5 years of age, very unusual for the Western world, with an even more striking male preponderance of 34:1. This cohort was less likely to have bulky disease, mediastinal or splenic involvement, and the outcomes were at least as favorable as that for older children. It once again highlighted to us that we need to evolve treatment strategies that focus even more on sparing this very young cohort from late effects. The 29% who had received empirical ATT prior to a diagnosis of Hodgkin lymphoma were more likely to present with advanced stage disease and B symptoms and have infradiaphragmatic involvement. The overall outcomes were similar because treatment was stratified for stage and B symptoms. At the time of initiation of this study, PET scan was not universally accessible to many of our centers. The modality for response evaluation was therefore left at the discretion of the treating team, which gave us an opportunity to assess the impact of PET-based response evaluation. Patients who had PET-CT-based staging and reassessment were much more likely to report adequate response and much less likely to be allocated to the radiation arm. Did not impact outcomes, but definitely it could spare radiation in a significant proportion of patients. Moving forward, the Hodgkin lymphoma group has proposed that only PET-CT-based assessment is incorporated in future studies, with assured support from a partner NGO for provision of at least 2 PET CT scans per patient to those with limited or no access. In September this year, we completed 5 years from the last patient enrolled, and the 6-year OS and EFS for the entire cohort is in excess of 90 and 81%. We concluded from this study that this strategy employed is non-inferior to more intensive treatment for patients with early stage disease, but may be suboptimal for patients with advanced stage disease. Risk stratification and response adaptation is now almost being universally adopted in the country. Of note, no patient has reported a second malignancy to date from this cohort. Moving forward, the currently ongoing study is aiming to specifically assess elimination of radiation in patients with bulky disease and adequate response. The Euronet strategy has addressed this question, but we have had reservations in India because many of our patients present with extremes of bulky disease and poor access to salvage chemotherapy and transplant if they were to relapse. So the study is currently enrolling and randomizing this cohort for omission of radiation. Patients who are not eligible for this randomization are being enrolled in the descriptive arm. The target recruitment is 700 and over 200 patients have already been enrolled. The core team has been able to employ central review of PET CT for accurate staging, bulk assessment, and response. We've also attempted to look at relapsed refractory Hodgkin lymphoma because access to intensive transplant and salvage chemotherapy is limited in our setting. This study employed again a risk-stratified response-based algorithm using gemcitabine as the salvage chemotherapy in view of its limited toxicity. Patients with low-risk Hodgkin lymphoma received only chemotherapy and radiation subject to good response after 2 cycles of chemotherapy, while those with high-risk relapse were assigned to the autologous transplant arm, as were those from low risk arm with suboptimal response at early response assessment. We just completed recruitment in this study very recently and will analyze the data in the next couple of years. But the striking observation was that the vast majority of patients assigned to the autologous transplant arm actually were unable to receive that treatment, again highlighting to us that we may need to look at alternative strategies for this cohort in our country. Moving forward, a retrospective study on use of immunotherapy in our setting is about to be rolled out in the near future. We are looking at a number of other aspects which answer relevant and specific questions relevant to our setting. To conclude, meaningful research is feasible in low-middle income countries despite the numerous challenges. Collaborative clinical trials in our setting need to address questions unique and relevant to our setting. Simple study designs and user-friendly data entry platforms encourage participation, and timely update and completion of studies have helped us to maintain momentum, and hopefully we will continue to retain that. With provision of clinical research office coordinators, we can hope to incorporate central review and more complex data entry in the near future. This editorial comment in response to one of the studies published from this work has reassured us that there may be more than one standard of care dictated by logistics, resources, and perhaps patient-reported outcomes in a country as large and diverse as ours. Finally, I'd like to acknowledge the collaboration of all patients and their families, all participating teams from the various centers, CanKids, the partner NGO that provides us logistic support and treatment support to many of the patients treated on these studies. Finally, I'd like to acknowledge Dr. Monica Metzer and Dr. Peter Cole, who peer-reviewed our study protocols for frontline and salvage chemotherapy, respectively. Many thanks for your time and attention.
Thank you, Amita. And I want to first of all begin by welcoming all of you, because I know over the last on INPHOG and Dr. Venkat on the ALL protocols of INPHOG, and now Amita on Hodgkin's. You're very welcome to put your questions in the chat box. And if you want to answer your question directly, kindly raise your hand and introduce yourself. We have 15 minutes for Q&As, and we can begin. So while others contemplate what they want to ask, I have a question for all the three speakers, which is for any organization or any FAs in context of how do you see that? And my second question is, each decade, I think a new generation of investigators would come, and people with, who are currently fellows will become junior faculty becomes senior faculty. How do you see newer people coming in, joining these efforts, and eventually being experts in their own right and leading these efforts? Thank you. And any of you can answer that. Thank you.
Raman, could you repeat that? We lost your voice in the middle.
Raman, your first part was not clear. I thought it was my connection issue. Yeah.
Okay. So the first part is, how do you scale up in a heterogeneous country like India, where you've got so much variation in healthcare? And the second part is, how do you groom and identify few PIs of all these studies? And then I can also see then Revathi raised a hand. Thank you.
Venkat, do you want to take that? Or?
I think Gauri ma'am can speak, because she spoke on the genesis of INPHOG.
Sorry, the voice was breaking. I didn't really get it very well.
Madam, Raman asked, how do you think that in a diverse country like India, you can bring all the investigators together, and how are you planning to get the new future fellows and junior faculty into INPHOG, because they are the ones who are going to lead the future trials?
Right. So definitely there is something called sensitization, and the importance of how the West has shown the world that clinical trials, cooperative multicentric trials help us find answers to difficult questions, because childhood cancer is a rare disease. And the second thing is that you're absolutely right. Even in the ICICL study you showed, there are 3 tiers. So we don't have to have one study to answer every question. We can have different studies. We have a large number of patient population. But I feel awareness and sensitization of how this can improve outcomes, I think that is critical. Advocacy is very important, I feel. Dr. Kathy Pritchard-Jones has a question. Can I read it out? Amita, this question is for you. How much of the impressive male excess in Hodgkin's lymphoma do you think is due to tumor biology versus healthcare access?
So Gauri, we are very clear that this is largely biology, because we do not see this gender disparity for any other cancer in our country. And we know that our cohort is younger. The younger cohort is almost entirely EBV-driven disease, with its striking predilection for the younger male child. So in fact, as we can see, the younger the age group, the higher the preponderance of male children. So it has made us question, our kind of premise for many other cancers, where we have always attributed it to gender bias or disparity in access. But at least for Hodgkin, there is clarity that it is mostly biology.
Amita, I have a question for you. I mean, you beautifully pointed out from your experience with Hodgkin's that we are under-treating the children with advanced stage lymphoma when we are catering to such a diverse country. There are people who can do all of the tests that are being done abroad, and then there are people who can do nothing. So if we have to have research and cooperative group trials that would include everyone, how do we go about balancing these two groups?
So, like Gauri already addressed that we are a large country with diverse healthcare access. And an example is the ARIA guidelines. It has 4 strata for, depending on what access you have. And in our country, even in my own institutions, we can have all the 4 strata in my own hospital. So it may not be, so there will be some studies that we can all equally join in. And there will be some others in which, it can address specific questions. Now, for example, our work has shown that ABVD is suboptimal for advanced stage disease. But it's not that every center has accepted that, because it is not, because they will end up having a very high treatment-related mortality, because even in the, centers which are have very experienced teams and all supportive care, we have seen a treatment-related mortality of 5%. So there will be some studies in which all of us join. There may be some studies which may have, which will cater to all different strata. Even these studies were stratified for early and advanced disease. But even in the currently ongoing studies, the low risk arm, we've allowed the treating center to choose ABVD or limited OEPA-based treatment. So I think we will have to have different answers for different conditions and different questions. Does that answer your question, Revathi?
Perfectly, yeah, thanks.
Any other questions? So then I have a question again for Amita and for Venkat as custodians of the trials of these 2 diseases. Now, we are fortunate in India to have a great number of physicians and researchers, and are improving our capacity continuously. Do you think there is a role for us to help our immediate neighbors in, say, Nepal and Bhutan and Bangladesh and Myanmar and Sri Lanka, where they may not be individually capacity to execute studies in the same way, and they could be given the opportunity, they may not want to join, but if they could have access to such studies, which they also face the same challenges of healthcare access, etc. So as a researcher, as an investigator, can we translate what we have done over here and bring others on board? Thank you.
So Raman, I'll take that first because it may be easier to do it for Hodgkin lymphoma. So I think that will help us in answering many of the questions much quicker. And a good way, so data sharing between countries, at least in our part of the world, is still a major challenge. But if we could replicate the same study, if we have a core team that agrees on the premise of the study, the format of the study, the data collection, and if we had identical platforms doing independently, and subsequently when the data collection is completed, we pool in data together and hopefully have a much larger numbers and are able to answer our specific questions much more robustly. I think that is definitely a way forward, and I think there's already been some interest from our neighboring countries who would like to work with us on this. So I definitely see that as one of the ways forward. Venkat,
Yes, Raman, I think we should replicate what's being done in Latin America. We need to have cross-border trials. And one way is to leverage National Cancer Grid, because I just recently heard that the National Cancer Grid is trying to expand to have a regional cancer grid involving countries in South Asia. So that's one way of initiating trials. I have had inquiries from my colleagues in Sri Lanka and Nepal, and I've shared the ICICL protocol with them. So yes, it's just ensuring that we meet the local requirements, guidelines, and laws, and it's just about one trial starting, and then I'm sure many more trials will come. Yes.
Thank you.
Venkat has a question in the chat box. Venkat?
Yes, the question of trying.
Yeah, hi, Trine. So we're just learning. ISCAL is just rolling out as we are speaking. The funding is coming to the individual centers. It's managing 30 centers is challenging, but it's a great learning experience. So maybe 4 years down the line, I can tell you how it went. But I had great help and support from all the centers and PAs, everybody pitching in to ensure that we are able to bring it on the ground. So lessons are being learned. I'm sure some data would come out in the next couple of months.
Trine, I can share something very early with you, and Venkat would vouch for this, which is the government of India, the Indian Council of Medical Research, rightly so has decided to focus on bringing the government hospitals, because that's where a lot of our patients get treated. And so the 25 centers we're going to join the ISCAL center are almost all exclusively from the government sector. At the same time, in India, we have many centers in the private sector and the charitable trust sector and other government centers who were not or who are not part of this ISCAL initiative. And we have been working on INPHOG with the Indian Council of Medical Research, and they have been very open to the idea of other hospitals joining this initiative as long as ways and means can be found to support them in terms of the research. A proposal for another 15 centers to join, who are not all government hospitals. So expanding the total cohort of the ISCAL from 25 to 40 should the funding come in. So that's just in the planning phase. But then, of course, the other aspects of implementation, as Venkat says, will take time to come. Thank you. Revathi, please go ahead.
Yeah, I just wanted to ask Venkat and Amita, with all of the trials so far, there was a beautiful paper from North Africa for the Wilms tumor study. They didn't do much, but just by working together, they saw an improvement in their results. So between over all these 5 years, have you noticed an improvement in survival and a reduction in the abandonment rates by just institutions working together, not making any major changes to what they were already doing?
So Revathi, I definitely think that just, like it has been shown in rest of the world, that by just getting onto a study, even if it is descriptive, outcomes improve. And we've definitely seen that the abandonment rate in the Hodgkin lymphoma studies is these studies is lowest that has been reported from India, even using retrospective, comparing with retrospective data. And definitely, as everything is being done in a timely manner, and you have access to referral to higher center for patients responding suboptimally, as has been done for the relapsed Hodgkin lymphoma study. I'm almost certain that this is happening. Whether we can document it in a systematic fashion, that I think we will have to see in the years to come, because we have only in the retrospective data to compare with.
Absolutely agree with what Dr. Amita has said. And what has happened is that most of the centers are now following at least standard protocols or recognized protocols, not that, people are using what they feel like. So that's a big achievement, that kids are getting the correct treatment across all the centers.
Thank you. I think it's the right time to finish the first half of this 90-minute session. And I'm grateful once again to all the speakers for the time, but also, for the great discussion. And thank you to all the audience. I will now hand over to Revathi, who will begin the second session by introducing the panelists, who will have brief presentations before we have Q&A. Thank you.
Thank you, Raman, and thanks all of you who have joined the session. And this panel is going to be great because we have 3 experts who have come here to share their experience and have done great initiatives to make collaborative research happen. But how can this impact on low and middle income countries is what we're going to talk. And they'll have short presentations of 3 minutes each, and then we'll have a panel discussion. It's a very short time, but I'm sure they are people that can give their experience and make help us on the way forward over the next 30 minutes. Our first speaker is Dr. Guillermo Chantada, who's the president of SIOP. He's also head outreach program, Hospital St. John II in Barcelona, Spain. Over to you, Dr. Chantada. He's going to talk about how he perceives the SIOP PARC program to help promote research in LMIC.
Thank you very much, Raj. It's a great pleasure for me to be here with you. I thank the organizers for the invitation. Let me just here. Just let me tell you a little bit. There's some delay. Okay. Okay. I think that we already dealt with the whys, right? So I would just summarize why SIOP decided to support the research, the clinical research in low and middle income countries, and how are we doing it. This came from Kathy's presidency. SIOP was looking for a big, impactful project to run. And at that time in the board, we decided that that would be to support research in low and middle income countries. And why? I think the reasons were already explained here in this presentation, because our reality is different. We see higher toxicity, as you showed, for Hodgkin's lymphoma. We have a higher risk of abandonment, as you also showed. Advanced disease and presentation. You mentioned a lot about the very, very bulky disease that you face. So, and also there is a limited availability or timing sometimes for other treatments that we need to do. And then we talk about evidence-based medicine, but which evidence? We need to generate the evidence to then apply it. And the evidence cannot be translated for high-income countries in many issues. So this is the why. And I wouldn't mention too much about this because you already mentioned about Hodgkin's lymphoma, but let me just briefly touch on what happened in Central America when the new services that were launched in Central America. I see that Sandra Luna is here. They tried to do non-adapted treatment for Burkitt's lymphoma. They just do what was doing better, the FAB protocols. They have 40% toxic mortality. What did they do? They learned from that experience. They adapted the treatment. They give a less intensive treatment. They go against the books. And then they had 8.8 toxic mortality, which is still a lot. But compared to 40%, they were able to improve the results in survival, but not doing the things that were done by the text, by just learning from their experience and adapting it and measuring it. So now they know how to treat these children better and improve with the results. So this is a very simple example. You show much better this in ALL and in Hodgkin's lymphoma in the previous presentations. And how? How is SIOP doing this support? We created this PARC program that was mentioned before. So this stands for Program for Advancing Research Capacity. So we decided at that time with Kathy, that was again Kathy's mostly that her work and the board at that time, we decided that SIOP will nurture the ecosystem. We are not going to do SIOP protocols. We are not going to, SIOP is not going to teach how to do the protocol. SIOP is going to support, it is supporting already the research capacity that you could do because you know much better. And as POEM exists in India, was briefly mentioned also by Venkat, I think, about the Gallup experience in Latin America, Cancer Africa. I see that Trine is joining us today. INPHOG, a new cooperative group now in Southeast Asia. So we decided that SIOP will support the already existent cooperative groups. Why? Because you already show us this way. We know that you mentioned that you did a protocol with no funding, with just a Google Forms. And that is what SIOP trying to support. And that is why we are leaning on the cooperative groups in low and middle income countries to be able to generate the evidence. So we did a needs assessment. We asked the cooperative groups what they need. It was not striking to see that they all said the same. Jan, you already said that. We need dedicated human resources. We need web platforms for data management, for secure management of data. We need to train the key personnel, the new people coming up. We need organizational strengthening because we need to receive funds, we need to receive data, we need to receive specimens. So that is what SIOP is currently supporting by PARC. So just briefly, thank you very much. It's a big honor for me to be here with you and to be supporting, at least with the modest amount that we are doing to the great work you are doing. Thank you very much again.
Thank you so much, Dr. Chantada and Dr. Kathy Pritchard-Jones, who breathed life into INPHOG and given us the seed money to move forward. It's my pleasure to introduce my friend and Professor of Pediatric Oncology at Tata Memorial Center, Mumbai, Dr. Girish Chinnaswamy, who's done a lot of work with CREDO, and he's going to talk about collaborative research through CREDO.
Thanks, thanks, Revathi. Can you hear me? Yeah. Great. Yes. Okay. Over the next few minutes, I thought I will just share our experience of about the genesis of the CREDO workshop and what it actually is meant to do. Yeah, so the CREDO workshop is actually an acronym for the International Collaboration for Research Method Development in Oncology. And the need for developing this workshop was based on the fact that 82% of, sorry, slides just gone. Yeah, the need for developing this workshop was based on the prevailing global cancer research scenario. So 82% of the oncology trials and 92% of the oncology RCTs are actually from high-income countries. And it is obvious to all of you, I'm sure, that only a fraction of the output of such research is actually relevant to the low and middle-income countries, for obvious reasons that the spectrum of cancers and the stage of cancers are very different. And there is an inherent difficulty in implementation of interventions, largely due to issues with affordability, cost effectiveness, and lack of adequate infrastructure to do the same. So there were also challenges to conduct research in low and middle income countries, many of which has been highlighted in the previous presentations as well, that there was lack of research training, the clinicians were overburdened, there was lack of research personnel, and the infrastructure and funding did not really support for us to conduct high quality research. So to offset this, it became clear that there was a need for multiple research initiatives which needed to be taken. And as part of the National Cancer Grid initiative to promote research in low and middle income countries, we embarked on many initiatives. One of them was to actually develop a clinical trial methodology workshop, which would train oncology researchers to carry out high quality context-specific research. So these researchers would answer locally relevant questions, which are readily implementable and cost-effective in a low and middle income country setting. There were already existing workshops globally which dealt with clinical trial methodology training. However, many of these workshops did not meet the need of the low and middle income countries because they essentially focused on early phase trials and drug development, which was not the need of most of the LMICs, and the research questions were very, very different. And hence, in 2015, we developed CREDO workshop as part of the National Cancer Grid of India initiative. We started off this initiative with the workshop mainly catering to the Indian trainees and the Indian participants, and very rapidly we moved it international since we realized that a lot of the development and a lot of the questions which were being asked were very, very relevant to many countries in the low and middle income category. So this workshop has now completed 6 editions, and we are now into the 7th edition, which will be held between 4th to 9th March 2024. So the objectives of the CREDO workshop, sorry, slides, yeah. So the objectives of the CREDO workshop was to train researchers in oncology in various aspects of clinical research methods, and they all came up with a research idea, which we helped them develop into a very structured protocol ready to be submitted to their IRBs or ethics committees. It also promoted collaborative research and naturally built research capacity in oncology in these regions. It is a very intensive residential 6-day workshop where 60 participants are mentored by 40 faculty. And there are a series of webinars between December to February, about 12 webinars which are conducted, training all of them, getting them aligned to the workshop. And then throughout the year, there are monthly webinars which go on as follow-up to actually help them complete their protocols and also answer burning research questions. So this is the alumni we have had from the Credo. Among this, of the 6 workshops we have finished, we have trained 322 clinical researchers so far, and amongst them 50 are pediatric oncologists. We have also had the opportunity to actually train 23 statisticians from the region and many others who are involved in research. So as I said, we started off with India initially, and now as you can see, we have participants from Africa, South America, Central America, and Eastern Europe as well. And these are all the different specialties of oncology who have been trained. And as you can see, the surgical oncology and medical and pediatric oncology are the largest group of people we have trained. But we have also trained palliative care, public health, pathology, and other specialists as well. So these are some of the publications which have come out in the last 5 to 6 years. Many of the trials have been completed. Many of the trials are underway. We keep a very real-time assessment of what has happened to the projects and do follow-ups. And I can say that more than 40% of the projects are actually nearing completion, and about 60% of what has been gone through Credo is actually underway, which itself is, we feel, is a great achievement which has been done. So we have numerous supporters for this. The pediatric numbers increased dramatically once St. Jude Global came in last year, and they actually supported all the pediatric oncology trainees who came from South Asia as well as from Africa and South America. But we have numerous other supporters from the WHO, from the MRC, ASCO, etc., who all have supported us both in terms of funding and logistics to actually conduct this workshop. So I think I will stop here, and that's what I have to present.
Amazing journey. Thank you, Girish, for sharing that. And I can say that few of the people I met who went to Credo and came back, they were totally transformed. So it was a real change in how they perceive research, collaborative research. So thank you for the amazing work. It's now my pleasure to introduce Dr. Nickhill Bhakta, who is Associate Faculty Member, St. Jude Global, St. Jude Children's Research Hospital in Memphis, USA. I mean, all of us ask the question of what should we do, but how much is it going to cost is his research interest, and has given great inputs into this aspect. We're looking forward to your talk on how will St. Jude Global help collaborative research in our country. Thank you.
Thank you so much, Revathi and Raman and all the organizers for inviting me, and of course the previous speakers who I only hope to live up to their examples. So just quickly, how is St. Jude going to be able to support the global work? And I think it very much is appropriate that I give this talk at the end here, highlighting that this is truly a global collaborative effort. And as you'll see, this is not about St. Jude, this is about the whole community coming together to really think about and how to address the global needs for childhood cancer as a broader community. And so, let's see, there we go. And so I'll start by just highlighting, kind of, if we think about this question, it always makes sense to come back to the patient and to define the problem by the challenges from the patient perspective. And so as you think about where we have seen at a global level issues related to childhood cancer survival, it really begins with identifying those children, referring them into care, ensuring that they get the correct diagnosis among those that are actually referred. If they're getting the correct diagnosis, how do we ensure that they're getting the best therapy related to the treatment options and the quality of care that's available locally? And then once we have that, we have to figure out how to make sure that they get the right treatments, like medicines, assuming that they have the right guidelines available. And then all of that has to occur within a system that provides quality care. So along that continuum, we see it's a complex value chain, and to use the business parlance, and things break down. And so that's really the pathway for this child with cancer. And so if we think about how can we as a community work on this, we've seen now the WHO enter the discussion with the cure-all package as part of the Global Initiative for Childhood Cancers. And St. Jude Global has produced policy and health policy, health systems tools, et cetera. We have seen PSYOP, CCI, PROS, St. Jude Global, and IPSO come together with the ARIA Guide Initiative. I think Amita already mentioned that for example, Hodgkin, now we can provide comprehensive treatment management tools. On the diagnosis side, we have a new initiative that we're actually starting and really focusing on India, actually, as our first part, to think about how can we bring low-cost molecular diagnostics that are standardized using cloud computing platforms, so that all sequencing happens in country rather than having to ship samples outside, which in 2023 is ridiculous. And then with the medicines, together with UNICEF and WHO, St. Jude Global has been able to now invest $200 million over the next 5 years to ensure that 50 countries and 120,000 children will eventually have access to quality, reliable, safe drugs without stockouts. And then, of course, the whole quality of care issue. How can we address that quality of care and make sure that every hospital in the world has access can do the best within the resource constraints that they have? And so one of the ways that St. Jude Global works then, beyond just the collaborations to develop the platforms and the tools, is through our global alliance. And this is 200 plus institutions and foundations from 70 countries with formal MOUs signed between St. Jude and each institution, but it's not a hub and spoke model. It's designed to be a network so that it's not just about your one person's relationship with St. Jude, it's about the community's relationship to one another. Because ultimately, that's where we see that innovation and successful implementation is not just through one institution supporting 200 plus. It's about that 200 plus ecosystem kind of working together in different ways to ensure that there's quality, that there's progress. And so that the alliance build is meant to be able to harness the community and provide organization and governance to support that. And so as a final slide, how are we able to implement this and think about this from a global level? So for us, it comes back to the concrete concept of adaptation, recognizing that adaptation, we use that term very lightly, but it's actually a very academic term in the implementation science literature. And ultimately, the only way adaptation works is if it's active, meaning that you're constantly working at it, and it's cyclical, meaning that you want to adapt, you readapt, and you further adapt, and you make progress. And so we've produced a variety of tools, such as ARIA, with many collaborators as well. We developed a standardized hospital-based cancer registry network, which is being used globally, including in centers in India currently. We developed Profile, which allows for hospitals and teams to understand the resources in their contexts. And then global packages, which are implementation science and quality improvement programs meant to be delivered at the hospital level to improve the quality of care. And of course, all of this exists within the health system and then policy needs, so that way we can work with governments to ensure that childhood cancer is never left behind. And so with that, thank you so much, and I will hand it over to the panel.
Thank you so much, Dr. Bhakta. I think as the quote says, it takes a village to raise a child. I think so many people are involved to make sure that that one child with cancer gets adequately treated after a diagnosis and followed up. So whoever is here who's tuned in, please feel free to ask questions, raise your hand or put it in the chat box, because we have these amazing panelists and this is our opportunity to make the discussion as lively as possible. There is one question from Sandra in the chat box to you, Girish, whether Credo certification is it valid in other countries? So what kind of a certificate is it?
Yes. So we do not have any accredited certification which is being done. So it is just that you have gone through a week of clinical protocol development workshop, and it gives you access to all the resources as well as all the educational programs which occur post the workshop as well. So we do not have any certification as such.
Okay. So if there are no other questions in the chat box, I think one of the major worries and concerns for people doing collaborative research together is on data sharing. So if any of our panelists could ask about what are the challenges regarding data sharing and how can this be addressed, please?
I'm happy to start, and I'm sure Guillermo and Girish will have also some thoughts. So we've tackled this quite a bit, and from the registry network that we've developed, thinking about Divya from a diagnostic side. And there's two competing components. One, ensuring that there's equitable data sharing. For too long, there's that history of colonialism in healthcare, especially when high-income countries dominate, or you see publications where it's the first author is a US or a European collaborator. And that, that has to stop. And we all recognize, I think, that. So one of the key challenges then is also, how do we bring the community together to actually make sure that we pool data, right? Because the days of single center institutional programs and projects, as Raman highlighted, are gone. And I think INPHOG has been a successful example of developing those publication guidelines, et cetera. So to address some of these challenges, what we've done is we sought out, and first of all, we worked closely with many of you on this call. How can we develop collaborative, equitable access and governance to data? And the first and foremost is ensuring that when there is data being generated through projects and programs, that each hospital or each institution is recognized to own their own data, that they can do what they want with it. It's their own data. There's no strings attached to that. But then create secondary mechanisms, right? And that's going to be where we can create de-identified databases, where we can create other mechanisms so that, or federated databases. So therefore that data can still be accessed for research purposes. And that's where the real key comes in. There has to be both a mechanism for active research and passive research. And this is really important as a concept, because the active research means that, if Raman wants to look at outcomes in India, Raman should be able to then look at that de-identified database with all of the INPHOG institutions to be able to understand that. But he can't do that by himself, because that data was generated by people. That data was generated through love, sweat, and tears. So how can we then ensure that those individuals who produce that data also get involved? And so that's where the passive component comes in. So for our registry and for others, what we've said is that people can propose ideas within the Global Alliance. Those have to be vetted by your peers for the quality of the analysis, to make sure there's no overlap. And then also, then they can actively analyze it. But anybody whose data that they use, they have to be incorporated as a co-author and give sign-off on the inclusion of their institutional data as well. And so that way, there's a recognition that individuals can lead, but at the same time, there's that ICGME recognition that if you're producing the data, that qualifies as authorship, and that should be recognized. So ensuring mechanisms like that, where teams have governance rules through their peers, but also have the ability to share data and have recognition of it, is really important.
Thanks. I think most people who had this worry, you have answered the question. I want to ask Dr. Chantada, please. You've got experience working in different parts of the world, and what do you think are the common barriers to effective collaborative research in pediatric oncology? What can we do to address these challenges? What can we do to get better?
Yeah, thank you very much. Yeah, that's a very important question. I think one of the jobs we have is to show that what we're doing is useful and we are saving lives. Because it is, I think the major barriers we found in my work in Latin America are usually the governmental authorizations, for example, for international research. So we have to show them that it works. There is a trend, as Nickhill mentioned, that it's usually that we should be doing what is being done in high-income countries. For example, in many countries in Latin America, if a drug is approved by the FDA, it's automatically approved in these countries for the same indication, which for drugs like anti-GD2 therapy doesn't make too much sense for us. So I think first we need to convince the governments that this is something we need to cure more children. And I think I found it harder to do that than convince our colleagues. Our colleagues are already convinced, but still it's a long way to go. Also, the IRBs sometimes are difficult. We have just done in the St. Jude Global Alliance study on lymphoblastic lymphoma, and about 1/3 of the IRBs. It was a retrospective study. anonymized data that didn't require approval by St. Jude. And this about 1/3 of the IRBs did not approve the protocol. And it was harmless. And by the way, provided great data, which will save many lives. So these things, but probably is in our hands. We have to show, we need to be better in showing that it really is saving lives of our children, and nobody would do it for us.
Excellent. Thank you for the lovely answer. I want to ask Dr. Girish, the word research itself, people are worried because that means my child is not getting standard of care. And even amongst people who are practicing every day, pediatric oncologists, if you say there's some research involvement, that there is a barrier, and to work together, there's a barrier in the country. How do you think through Credo we're going to change things, or over time, what do you perceive will be the future of collaborative research in our country?
So I think there are two issues here. One is when you talk about research, one is from the patient perspective, that they actually feel that there is actually some experiment being done on the child. And so we need to, first of all, reassure the parents when we are dealing with the research component that the standard care will not be affected, and actually the risk benefit actually supports most of the time that the child to actually participate in the research, and there is more trend towards benefit than harm. So that is from the patient perspective how we approach it. To actually make a collaborative research and among the medical fraternity was actually quite hard, as Venkat did very rightly show. That the ICICL study took a really long time. The first meeting was in 2012, and actually the study started in 2019. So it took a really long time to actually get this going, for the reason that there were two major barriers. One of them, people were used to their own protocols, how they were doing, and they had a comfort zone within that. And being the first multi-center intervention trial in the country with randomization in pediatric oncology, there was a hesitance or barrier of what actually it would involve. And that's why what started off with multiple centers actually came down to only 6 centers ultimately participating in the ICICL trial, because many of them did feel that it was difficult to do the trial, and there was an inherent hesitation on an experimental protocol, etc. But now, having done the proof of concept, you can actually see that the uptake for the ICICL2 and the implementation study is really so high. And that has been the same case with the Hodgkin's lymphoma as well, which Amita has shown as well. So I think the first thing is to show that this standard of care is not getting affected. And that's what we are planning to do. And we have a consensus between all the participating centers that this is the standard of care which is acceptable to all of us. And if we actually do that part well, then the randomized question is actually much, or the trial intervention is actually much smaller issue to deal with. And I think that's where we actually need to focus on.
Thank you, Girish. There's one question from Navya Pillai, and how we can collectively address and mitigate the side effects experienced by individuals who've undergone childhood cancer treatments. And from your experience, would you like to answer that, Dr. Chantada? What are we doing through research to reduce long-term side effects or to mitigate the side effects? What have we learned, and what can we do better?
Well, I think this is one of the major things we have to contribute yet. I think we made good efforts in low and middle income countries in showing data, in preparing analysis like were presented today and for others. But I think we have not done enough yet on long-term side effects. However, as we discussed, as you've shown for Hodgkin's lymphoma, we are very much aware, the same as in other treatments like retinoblastoma, for example. So I think that's even a bigger challenge for us, because it needs to follow the patients through the adult life, which we know is usually problematic in our settings. And I think that's a very much pending issue. I think we have to learn much more. We know very little about that.
I think we have got amazing example of the St. Jude Life cohort. So we have here the C2S study in India. And as we learn from that, we'll be able to adapt and change protocols right at the very beginning and address these side effects. There's also a question from Dr. Shruti Kakar. And she says that India is a vast country with differences in healthcare systems. How do we ensure the collaborative research is inclusive? Any of the panelists, maybe Nickhill, thank you. You can address the differences and how much a person can afford. So how do we address this and how to make research inclusive?
Yeah, no, I think that that's a fair question. Of course, I would also defer to Raman and Girish from their perspectives as well. But yes, I mean, I think that it's not just India as a vast country. What I think is interesting is that while there may be two institutions that are very different in India, that there may be a similarity between an Indian institution and a Mexican institution, or an Indian institution and a Kenyan institution. So with these global collaborative networks, it's not about geography alone. It's about utilizing tools such as Profile, identifying and benchmarking what your resources are, seeing who has similar profiles to what you have in your setting, and then utilizing that data to drive forward. And research does not only mean conducting a phased clinical trial. Research can be implementing a program. Research can be quality improvement. Research can be many different things that can make a difference in reducing mortality and morbidity to children with cancer. And so expanding one's definition and thinking more local regionally rather than just only locally can also make a big difference.
Okay. Raman, do we have more time or should we close because it's 7:33 now?
Okay. No, I was going to say that beauty of having Zoom account is that for those who want to go to another session of London Global Cancer Week are welcome to exit. But otherwise, we have time over here, and we can definitely roll on and keep answering the questions which have been raised over here. I think some of what Shruti has asked was covered in the first session when Amita and Venkat and Gauri answered this. How do you carry everybody with you? I also noticed the comment by Sandra on sustainability. And I think a good example is of the ISCAL study, the implementation study for ALL, which is where a smaller multi-center study on ALL, the ICICL 1, led to improvement, which encouraged the Indian Council of Medical Research to fund a larger study to make that same improvement happen in much greater number of hospitals and impact much greater number of patients. And that is how slowly you can get the official ministerial government agencies on board by demonstrating success. I mean, we are doing something called the Indian Childhood Cancer Initiative, and this is not the platform to talk about it. But the point I wanted to make is that in India, we have found that government is keen to engage and promote, but they're also looking for somebody to find a solution and implement a solution which they can then upscale. And so if we can do that at a smaller level, and that's why SIOP Park funding is so important for us, that if we can demonstrate that at a smaller level, we can then approach the relevant agencies and leverage our experience and knowledge for greater amount of funding and sustainability. Thank you.
Dr. Chantada, if from the SIOP Park experience, if you can give us one major or just a few pearls of wisdom, what is it that you would like to share to say how to make things move fast track things, because you don't want to be reinventing the wheel?
Exactly. That's why we just went to groups like INPHOG, because we know the work that you are doing, and we wouldn't want to create a new group. We wouldn't want to support groups that were not so impactful. So this is what SIOP decided at some time. And also we have something that we are about to release. We announced, and we are going to give career awards, also thinking of the young people, as was mentioned recently. And for that, we were lucky that we have a donor, but we went again to the cooperative groups and say, for example, you need to train someone for leading a strategy, I don't know, in long-term side effects, for example. There is one presentation on that, because the group decided we don't have a person on that trained, but we need a program. So that's why that's where we are going, where we SIOP want to help. So providing this career award to young investigators to fill a gap in the needs of their cooperative groups, get the best training they could, and then hopefully sustain the support throughout the years.
So there's also a question from Rishika, who's asked if there is research that's possible in one area and implementing it in another region, even within our own country, that can be difficult. So amongst the Latin American countries, when you had such challenges, what did you do to overcome that?
Oh, that's a really great question. And that is a big challenge, because I think we need to work with huge inequalities. And first, I think we are already there. We needed to understand that the European model, like national groups, are very good in equal societies, but it's not good for societies like in Latin America, where there's so much inequality. So a national group will not do, and a national group doing everybody the same will not be the way. So first we have to accept that inequality and different access to care, as was mentioned before, needed to be tackled. And it didn't mean that the one group that can do research and the other groups couldn't, because they are not good enough. So once we understood that, we are now working on different strategies, tackling different problems in different regions, but working together as a region. So that is what the current challenges at the Latin American protocols, to deal with inequality. Absolutely.
Yeah. Thanks. I think there's one question from Dr. Sanjeeva Gunasekara saying governments are increasingly tightening regulations around data collection and sharing. And has INPHOG faced similar issues, and how did you address it? So, Girish, do you want to take this from a government organization? Yeah.
Yeah, so you're absolutely right, Sanjeeva. There are regulations which are quite stringent in place to share data, biological samples across international borders. So within the country, it's reasonably okay. It only requires the ethics committee approvals of the individual centers to pool or share data. However, over a period of time, there has been restructuring of the process, and that has only happened because of the numerous representations done from various societies in the country, as well as individuals and institutes, that the approvals for doing international collaborative trials were actually taking too long a time. And now it is much more fine-tuned. So if you ask me what are the timeline, initially, say in 2015, it would take about 2 years to get approval from a government to do an international trial. After the hundreds of representations and meetings which took place, now it takes about 3 months only to get approval for an international trial, provided your paperwork is fine. So then it's only queries which come after that. So that's where we stand with it. And it required societies, the National Cancer Grid, the ISMPO, institutions, all to make a representation to the government to tell that this approvals are taking too much time, and now it's fine-tuned. So that's how we actually did it in our experience.
So thank you all. It's my duty now to thank everyone. Maya Angelou said, do the best you can until you know better. And then when you know better, do better. So I want to thank the London Global Cancer Week and Dr. Kathy Pritchard Jones for connecting us, and Emma Jane for helping us in making this whole session happen. The INPHOG team, Rishika and Navya, for putting together all of the effort to bring this session together. All our experts and panelists who've shared experience, and the audience who've shared your time with us and made the session interactive with your questions. Thank you so much.
Thank you all. I think we can now